Hello everyone, it's Dr. Oliver. We're going to do the second episode in our antibiotic review. So this next episode, I want to kind of go into specific locations, and for this second episode specifically, we're going to talk about skin and soft tissue, and we're just going to talk about common infections and then some of the typical antibiotics that we'll use for that location. Okay, so let's talk about MRSA. I'm sure that you guys have seen a patient you can probably think of where they have had some sort of skin infection and it turned out to be MRSA. So MRSA can be caused by overuse of antibiotics as well as inadequate infection control measures. And what that means basically is, people are not washing their hands appropriately, or, they're not necessarily using sterile materials during a sterile procedure, and, et cetera, et cetera. The mechanism of resistance seems to be target modification. So if you think back to that first episode, we talked about how superbugs occur, and MRSA occurs through target modification. So over time, the number of infections caused by Staph aureus has not changed, but the proportion of infections due to MRSA has increased substantially. And this is because, again, we're overusing antibiotics, and this bacteria is becoming smarter, and we also need to focus more on infection control measures as well. So this bug is most common in hospitals, critical care, and long-term care settings. It can also be acquired in the community, though. So Staph aureus infections result when patients who are carriers infect themselves. So MRSA is one of those things, I'm sure you have heard of this, where a person can be colonized with it, but it does not necessarily mean that they need antibiotics because it's not an active infection. So there is a difference. We do not treat colonized patients per se unless there is a reason. So if they're going to go into surgery, or they're immunocompromised, or maybe they're around a loved one that is immunocompromised, then we would consider treating that. But typically the majority of the population is colonized and they probably don't even know it. Carriers can infect immunocompromised patients. So that's probably the big thing to remember when you're talking about MRSA. So let's talk about hospital-acquired MRSA now. This is the big one that can it can really cause a lot of problems for people, and it's the one that I more commonly see just because I am in the hospital. So an increasing proportion of hospital-acquired Staph aureus strains are methicillin-resistant. So initially this was first reported in the 1970s, and the prevalence has just continued to increase, especially in bigger hospital institutions. So usually it involves various types of infections. So bacteremia, intravenous lines is a common site, pneumonia, skin and soft tissue infections. The transmission is typically person to person. The growth rate is usually slow, and then it's resistant to multiple antibiotics. So again, the people that you really have to watch out for are your immunocompromised patients, or perhaps your patients that are in stage disease that causes their immune system to be a little bit less appropriate than what it should. So it puts them at more risk. Your diabetics, people that have some sort of neurological disorder that cause their feeling to be diminished. All of these cases put them at more risk for developing MRSA. Now, when we're treating inpatient MRSA, typically we will first give them vancomycin or Zyvox. I'm sure a lot of you have heard of that. Zyvox actually can be given in the home health world as well too, and typically that's daily dosing. Depending on kidney function, they can tweak that a little bit. Vancomycin typically is daily dosing as well, or they can split it up into 2 smaller doses throughout the day. It just depends on what the peak and trough is. Usually what we do, and a lot of pharmacies in the hospital setting will do this, they usually like to take control of determining what dose of vancomycin to do. So they'll look at the blood work that's drawn that morning, or around right before the dose, and then they will decide what dose to give that patient. They'll also look at kidney function, and that will help determine the dose as well. So it's kind of nice for us providers in the hospital because, not always do, well, especially for me, not always do I get to see the same patients. So having the pharmacist who they're a little bit more consistent, having them follow it makes it more consistent for the patient. So that's just really nice. So we talked about this a little bit, but what are some other risk factors? So older patients that are older than 75, prolonged hospitalization, and usually that's greater than 3 to 4 days, critical care stay, so someone that's in the ICU, long-term care resident, prolonged antimicrobial therapy, so those patients that perhaps they have a diabetic foot ulcer and they're on 21 days of antibiotic therapy, they're more prone to MRSA infection. Surgical procedures, a person on dialysis, any person with an indwelling medical device of any sort is at high risk for MRSA. And then close proximity to a hospitalized patient who is infected and colonized with MRSA, which is why we put these people in their own private rooms. So we talked about this a little bit. Usually MRSA is very resistant to multiple antibiotics. It's very resistant to penicillins and cephalosporins. It may be resistant to clindamycin and Bactrim. So usually clindamycin and Bactrim are actually very appropriate for any sort of skin infection. However, it's important to do a good subjective history on your patients, because if they have multiple risk factors for MRSA and you don't have a culture yet and you're trying to figure out what to order for them, you may not want to order clindamycin or Bactrim because they may come back positive for MRSA, and those two antibiotics would not be appropriate. So, for example, I have one patient. He's a diabetic, so he comes in for foot ulcers all the time, and he usually ends up leaving AMA. He'll get like a few days worth of antibiotics and then leave AMA. The first couple of times I saw him, it was not MRSA positive, so we had used actually clindamycin the first few times, and then as his disease progressed and as he progressed in his lack of care for himself, he actually developed MRSA in that wound, and so we were no longer able to use clindamycin, and really after that initial time when he tested positive for MRSA, now every time that he comes in, we don't even use these medications. We just automatically go to vancomycin. So if you really have a big suspicion for an infection on a person being MRSA, then I just would skip these antibiotics and go right to vanco. Now, when you use Zyvox, so Zyvox at Marion General and for a lot of the hospital systems, and I know for any of the Ohio Health hospitals, when you are using Zyvox and you're ordering Zyvox, that's an automatic ID consult, because that medication has to be monitored very closely, and it's a very big gun medication, so they want the big gun consult on board to monitor that. So just think about that if you have a patient with that. Usually we will order Zyvox when people they'll have an allergy, a pretty severe allergy to vancomycin. So they just, for one reason or another will not tolerate it, so we have to use Zyvox. Okay, so we've talked about hospital-acquired. Let's talk about community-acquired MRSA. So initially this was reported in the late 1980s. It was thought really to be linked to hospital-acquired MRSA, so you'll notice that in the previous slides, hospital-acquired MRSA was first reported in the 1970s. So really the first case of community-acquired, it took about 10 years for it to spread out into the population. So more reported infections lacked this correlation, so it suggests that a new and different reservoir of MRSA had developed in the community. So it's really unsure if the two are, caused one from the other, or if the other one just kind of developed on its own. There does seem to be a correlation between sharing of close quarters, though, and transmission is still person to person. Growth rate is usually fast for community acquired. So these are infections that pop up overnight, and I'll tell you a story here in a second. They are very resistant to beta-lactams, but sensitive to many other agents. So the story I was going to tell you about is actually about my daughter. And so children that are still in diapers are actually prone to community-acquired MRSA infections around their diaper line, especially if their parents work in the hospital setting. So my daughter, she was about 9 months, and the night before I had noticed that she was a little fussy and she really didn't eat as much, but she would do that periodically when she would go through growth spurts, so we had kind of thought that that might have been what it was. We didn't necessarily see anything on her skin at that time, and she wasn't running a fever, so really there was nothing out of the ordinary. That whole night she did not sleep well, so we were up with her all night, and then by the time it hit around think it was like 4 or 5 in the morning, we noticed that she started feeling warm. So I had checked her temperature, and she was in, at that, I think the first one was around like high 101. And so, you know, we had given her a little bit of Tylenol, and then I had gone to change her diaper, and I had noticed that she had this little red lump, on her right side, on her back side, on her diaper line. And, it just looked like a big pimple is what it looked like. And so, I didn't really necessarily know what it was, at the time. And, we just continued to kind of keep watching her. So I had put some cream on it. I had made sure I kind of pulled the diaper back a little bit so it wouldn't, be continuing to rub on that. And then I just watched it really closely. Over the next hour, it actually developed a yellow head on it, and then about an hour after that, it ended up popping. And when it popped, it actually was like an orange pus is what it was, and it smelled horrible. So I knew right away that it was obviously something not good. So, and I figured it kind of looked like MRSA, so I had taken her in. And they ended up hospitalizing her because in a matter of 24 hours, it had actually started to tunnel a little bit. So she had to go in, and they had to IND it. It was just a horrible experience with her. But it really, I guess I had underestimated how quickly a community-acquired MRSA could go, because, you know, I usually, I check both my kids over, you know, when I was changing their diapers, and I never noticed anything on her, and she was feeling perfectly fine the day before, and then all of a sudden within 24 hours, you know, she had that, and with the orange drainage, and running fevers, and just really cranky. And so she ended up actually being in the hospital for 4 days, and she had to get clindamycin IV. So after that, she was perfectly fine. They actually had to go in and drain it twice. But it was just, you know, it was scary, of course, but it just really was a big learning lesson for me. So just keep that in mind. It actually can come on very quickly for patients. Okay, so what are some risk factors for community-acquired MRSA now? So not really clearly identified. Typically, though, it's younger patients, the median age of 23 years, and compared to 63 years for the hospital-acquired MRSA. Chronic non-infectious dermatologic conditions such as eczema were most common as an underlying issue for those less than 18 years old. And I will tell you, that is one thing that ended up being with Raylan, is that she actually had as a baby, and she still does a little bit now, but now I think we've got it more under control. But she had really bad infant eczema. So she, we just really kind of struggled with it for a while because it was hard to control. Now, as she's gotten a little bit older, it's been better, but this was a factor in why she got MRSA. Also, people with any sort of, new tattoo, they need to be careful, or any cosmetic body shaving, any injectable drug use. And typically it can be found among older patients, greater than 18 years old. Other underlying conditions include smoking, diabetes, dermatologic conditions. So let's talk about some antibiotic therapy for community-acquired MRSA. When you're treating community-acquired MRSA, it is similar in many ways. However, there's a couple of differences. So when the infection is specifically skin or soft tissue, usually an incision or drain, if I can talk right, incision and drainage is needed of the area. And why this is because MRSA, again, is just a very smart bacteria. It creates a capsule around the area of infection, and so it makes it hard for the antibiotic to go in and access that bacteria in order to kill them. So when we go in and do an incision and drainage, we allow that pus, that drainage, to come out. So it really gets rid of a large bacteria load. And then also it physically opens it up so the antibiotic is able to access that bacteria to go in and kill the bacteria. So usually community-acquired is resistant to beta-lactam. So we're talking about penicillin, amoxicillin, so the cephalosporins. So one of these types of medications that you'll see providers use a lot of in cellulitis is Keflex. It works great for Keflex, but not for community-acquired MRSA. So Keflex would not be, should not even be considered for use. Usually community acquired, and this is where it differs from hospital acquired, but usually it is sensitive to clindamycin, Bactrim, minocycline, doxycycline. So doxycycline I actually really like because it is safe for patients that have any sort of level of kidney disease. And you know, as you guys have seen probably in your clinical settings, a lot of our population has some sort of kidney disease. So doxycycline, if it's a community-acquired MRSA and they're a first-time offender, is what I like to say, doxycycline usually works really well. I usually do 100 milligrams by mouth twice a day. For MRSA, if I know for sure it's MRSA, I'll do 7 to 10 days. Otherwise, my other one that I like to use is clindamycin, and I'll usually do 600 milligrams by mouth every 8 hours, and I'll do that for, well, depending, so if they're a first-time offender and the infection area does not look horrible, then I'll do 5 days. Otherwise, I've gone all the way up to 14 days with clindamycin, depending on how bad the infection is and how many times they've had this MRSA infection there. Clindamycin is one of those things, though, that you have to be very careful with because it does cause C. diff very easily. So clindamycin especially, but really anytime I use an antibiotic, I always encourage my patients to eat like an active probiotic type yogurt. So a lot of the like Greek yogurts have active cultures in them, or I suggest different probiotics for them to use. I really like the Phillips brand at Kroger's. If you're suggesting a probiotic, you want to make sure that that probiotic that you're suggesting has at least 3 strands in it. One of the only probiotics that has been studied and shows some activity against C. diff, or the C. diff spores, is a probiotic called Florastor. It's just, unfortunately, one of the bad things is it is very expensive. However, I know Kroger's does, I think Walmart does too. They do carry like either a 5 or 7 day dose of the Florastor that is fairly, is fairly well priced. So if you have someone that perhaps has had C. diff in the past, or they're just really concerned about it, then I would encourage them to go and look at that 5-7 day dose of the Florastor. And that's an over-counter probiotic. All the probiotics are over-counter, so they would be able to go and order that, or purchase that.